Hi, I'm Dr. Ralph McKibbin from the Alliance for Safe Biologic Medicines. I'm going to give a synopsis of our poster presentation from the Global DIA meeting in Boston, Perspectives of Canadian Ophthalmologists on Biosimilars. So in background, biologic medicines have been around for quite some time. They're highly effective and usually used to treat chronic conditions that tend to be kind of expensive to treat: rheumatoid arthritis, psoriasis, ulcerative colitis. Biosimilars have been developed in the hope of driving down pricing, increasing competition, and they do provide another option for people. There is a high cost here, so the payers are incentivized to switch to these lower paying or lower cost medicines. So while they're safe and effective, we do want to make sure that they're safe. In the field of ophthalmology, the first biosimilar just came out recently, and there is a little bit of a difference in that instead of just an IV or an injection, they inject directly into the eye usually, although there are other options out there. So there are new concerns that ophthalmologists are raising, and we wanted to review their opinions on what's going on. So the objective was to survey ophthalmologists on biosimilar substitution, pharmacovigilance, and their attitudes towards prescribing. In addition, we also looked at product identification and pharmacovigilance. So this is one of a series of surveys done over the years, dating back to 2011. Most of them are multi-specialty surveys done in different countries around the world. In 2014 and 17, we had Canadian surveys done, but ophthalmologists were not included. So in partnership with the International Federation for Aging, we created a questionnaire and sent this to ophthalmologists practicing in Canada. We had an N of 41, 54% of these people were in Ontario. So the first question then in results was, what is the confidence level of ophthalmologists for the use of biosimilars? And in fact, it's high. 83% of ophthalmologists are comfortable prescribing them to a new patient. This is consistent with studies in the past. In addition, 62% were comfortable switching a patient if the physician directed the switch. The idea, I guess, is that they're worried about potential side effects. Historically, it does take years for patients and physicians to come up with a treatment plan, and so changing a stable patient is a concern. The negative impact came in, however, with third-party non-medical switching. 81% of respondents were not comfortable with a third-party payer, such as the government, switching a patient's medicine for non-medical reasons, such as cost. And this is increasingly the policy among Canadian provinces. It's also consistent with the multi-specialty surveys conducted worldwide. I will say, for those who have the poster in front of them, there's a QR code where you can access the prior posters. So the idea then is, the treatment decision authority seems to be at play here. So what we're looking at is who is in charge of this decision making. 90% of respondents said that having sole authority with the patient was important, and so they want to be able to direct the treatment. 91% considered the ability to prevent a forced switch by a public or private payer to be very critical and important. So not only the ability to make the decision, but also to prevent such a decision. 76%, however, did say they would support the patient's right to choose the appropriate treatment if the treatment gains did provide some risk to switching to a biosimilar, so patient autonomy is at play here. In terms of avoiding inappropriate or inadvertent substitution, while Canada does not currently require distinct and proprietary names for biosimilars, the survey found that clear product identification is highly important to the respondents. When reporting an adverse event, 78% use the product's brand name to ID the medicine, and 20% use only the INN, or the International Non-Proprietary Name. This is shared by the originator product as well as all the biosimilars. 2% use Canada's country-specific identifier, the DIN, or drug identification number. 88% of the respondents then would support Health Canada harmonizing with the international distinct naming standard, such as the suffix-based system recommended by the WHO, where the four-letter suffix is placed on the medication name, which would then promote more accurate pharmacovigilance. In summary, then, the preferred biosimilar access scenario, going back to the prior data, 78% of respondents said that their patients would be best served by a European-style access scenario where multiple products are included, as well as the innovator and biosimilars. This creates competition, but encourages new patients perhaps to go on less expensive medications. Only 15% preferred a system similar to that of the recently announced Ontario policy, where only government-chosen biosimilars are available. New patients must be prescribed these products, and current patients are forced to switch. So our conclusions are a few. The survey revealed high confidence in biosimilars, especially for new patients. A majority of the respondents were comfortable switching a stable patient if they directed the switch. An overwhelming majority were uncomfortable with third-party substitutions directing switches for non-medical reasons. All physicians considered it very important that they're able to prevent a forced switch. These attitudes are consistent with large-scale multi-specialty surveys done previously and stand in stark contrast to the forced substitution policies emerging in the Canadian provinces. By a factor of 5 to 1, respondents preferred the European-style biosimilar access scenario where there is freedom of choice for multiple reimbursed products, including the originator and biosimilars. Biosimilars, of course, are encouraged for new patients, automatic substitution not being permitted, and no forced substitution is required for stable patients. These results suggest that the Canadian healthcare system should prioritize patient choice and access to a range of treatments and achieve cost savings as in the European countries through competition rather than forced switching. On the pharmacovigilance, the survey revealed a strong preference for distinct biologic nomenclature and harmonization with the international suffix-based system recommended by the WHO. So this is also used in the United States. These would facilitate more accurate pharmacovigilance and help prevent inadvertent and inappropriate substitution. So we feel these findings should inform policy decision makers regarding the use and reimbursement of biosimilars in Canada and provide guidance to other countries grappling with similar decisions.